All right, guys. So let's talk about pediatric integumentary. So we're talking about the skin, right? And a lot of this should be fundamental information and then review from fundamentals or maybe some second level. So it's typically lower level content. So here's your objectives. They're pretty self-explanatory. I'll let you read them. So first, like we always do, we'll talk about the pediatric differences, specifically in regards to the skin. So there are four main ones. Pediatric skin, especially infant skin, is much thinner than older adolescents and then adult counterparts. So this places pediatric patients at risk for breakdown. So we want to be assessing at appropriate intervals and then implementing those interventions that you guys have learned about from fundamentals. And monitor for infection because they'll be at increased risk for infection due to that increased risk for breakdown, right? They also have a greater body surface area than adults. So this results in a couple of things. So they're going to be able to absorb topical medications at a greater capacity than adults will. So they're going to need different doses. So all that to say, we don't want to be using adult medications and adult dosages as far as topical medications on pediatric patients, right? They're going to need probably smaller doses. And then we also want to make sure we're only applying that thin layer of medication to that affected area. That greater body surface area also results in greater losses from sweating, and then also greater losses from just, heat exposure. So we want to be monitoring their fluid volume status and hydration and all of the assessment data that goes along with that. And then also keep pediatric patients, especially tiny ones, away from the extremes of heat and cold because they're just not going to be able to tolerate and adapt to those like you and I would. Thirdly, they have a lack of sub-Q tissue, which we've talked about already. So this also makes thermoregulation a problem. They don't have that really great layer of insulation like you and I do. So they're going to get colder easier. This also places them at risk for hypoglycemia. So when you go to OB or if you've been in OB already, you've learned about brown fat versus yellow fat. Brown fat is that really great insulation fat that we have that we're able to metabolize and break down whenever we get cold. We're able to use it as a source of heat. And then also we can break it down as a source of energy and glucose if we need to during times of stress. But small infants, pediatric patients don't have that. So places them at increased risk there. And then lastly, they have immature sweat glands. So think about what the purpose of sweat on and, within our bodies. The big reason that we sweat is to try to cool ourselves off, right? That's like the function of sweat. That's why we sweat. And so pediatric patients can't really do that as well. And so they can't dissipate heat as well as adults and older, adolescents can. So this increases their risk for hyperthermia as well. So general nursing interventions, these are all very fundamental concepts. Your book goes through them in detail. All things that you should have learned already. So I'm not going to waste time re-lecturing them. If you don't feel comfortable and confident with them, then please go through and read. But like I said, it's all very, very fundamental stuff that you should have learned already in first level. And there's really great patient teaching points in box 30.1 as well. So the first conditions we'll talk about will be infections. We'll cover impetigo first. So impetigo is a bacterial infection that basically results from an imbalance of good and bad bacteria on our skin. Typically, Staphylococcus aureus is the culprit, and it takes advantage of certain risk factors that our patient is going to have. So that's going to be skin breakdown, areas that are moist or, remain moist a lot more than other areas, patients who are very young in age, and then also those who have poor hygiene. So you might see this in infants and young children just because they don't have a very robust normal flora. And and they also, get cuts and scrapes and things like that. So this spreads very rapidly, um, especially things that are touched a lot. So, kids touch their mouth and then they touch this and then they touch that. And then, they never wash their hands. So it spreads rapidly from hands, towels, linens, other objects, and things like that. So our presentation, it presents with these kind of characteristic honey-crusted lesions. They might start off, you can see the pictures at the top, they might start off as, fluid-filled vesicles around the mouth and the nose, and then burst open, and then they kind of crust over with that honey-colored crust. And that's very characteristic for impetigo. And typically, the providers are gonna make their, diagnosis based off of the physical assessment. It's, like I said, pretty characteristic. So our treatment here, it's usually a self-limiting condition. We'll see topical antibiotics. That's going to be mupirocin or Bactroban. And then, possibly depending on the extent of the case, or maybe if it's, a particularly invasive case or it's recurrent, we might see PO antibiotics prescribed as well. And your book goes over those in the pharmacy 30.1. We want them to clean the areas with warm soap and water, use a designated washcloth and towel so we're not spreading it to everyone else in the house. Let daycares and schools know so that they can clean and, let the other uh, people around the child know that, they could potentially have been exposed. We want them to wash things in hot water, clean things with uh, cleaners that are active against staph, right? And it can lead to cellulitis, which we'll talk about on the next slide, and then some other more severe conditions. So we definitely want to, treat it effectively and promptly. All right, cellulitis. So this is infection and inflammation of the subcutaneous tissue, typically by strep or staph bacteria. MRSA is a frequent thing that occurs in pediatrics as well. And typically it occurs as a secondary infection when we have other risk factors that are present. So typically there has been some kind of trauma or inoculation of that bacteria from a bite or an injury or some other lesion. It most frequently occurs on the extremities. It also can occur on the buttocks, especially with babies in the diaper area. So it's going to occur more on the extremities because of how it's caused, right? Kids are typically falling or getting bit by things on their extremities, getting cut, scrapes, that kind of thing. And so that allows the bacteria a portal of entry into the integumentary system. And then with diapers, a lot of the times we'll see this, in those skin folds or, on the little butt cheeks of babies if diaper changes are not, the cleaning during a diaper change is not as thorough as it should be, or things are getting stuck, in those crevices and creases and all that good stuff. We can also see an increased risk with patients that have poor hygiene, exposed to dirty water, if they have a wound that's draining from somewhere else, and that drainage gets in a cut or something like that. Our assessment and diagnosis. So typically diagnosis is going to be made based on the physical assessment and history of the patient. They're going to present with our cardinal signs and symptoms of infection, right? And I've got a red cardinal there for you to help you remember. So if you look at the pictures on the right of the slide, you can see that's the, calf of a small child, and then the periorbital area of a child at the top, the picture at the top, so that those sites display all the cardinal signs, right? They're red. If you touch them, you'd expect them to feel warm. They're swollen, probably painful. All of the cardinal signs, right? This patient is also probably going to present with fever. They might have chills. And then the lymph nodes around those areas that drain those tissues are probably going to be palpable and kind of enlarged as well. So more definitive diagnosis can be done with a culture. If they're going to go in and do an incision and drainage, they can get a culture that way, or if there is part of the area that's draining some kind of, purulent fluid, they can culture that as well. In immunocompromised patients or infants, or if the cellulitis is particularly extensive, we might also see blood cultures drawn. But typically they're going to start with antibiotic coverage that's going to, cover staph. Typically, we will see, we try to manage this outpatient with just PO antibiotics if we can. But certain instances, like I said, if the patient's immunocompromised, they're an infant, it's a very extensive infection, or if it's not responding to PO antibiotics, you will see these kids admitted, for incision and drainage, and then IV antibiotics as well. And then your book has the pharmacy 30.1 and 30.2 that goes over the commonly used antibiotics for those. We want to be sure, a very big intervention on our part is going to be marking the site. So you can see in that bottom picture, when the child presented, they marked the outer area of the erythema and the inflammation. And then, a lot of the times it's very important to put the date and the time as well. And then as time progresses, they will, continue to mark as the redness and the inflammation spreads. And that gives us a lot of good data about, how quickly the infection is spreading, how aggressive it is, and also if the interventions that we're implementing are helping, right? So that's very important. Also, I've mentioned, if we drew, when we draw labs on this kiddo, what would we expect their white blood cell count to do? Go up, right? Because they've got an infection. And then also, if we drew inflammatory markers, so our C-reactive protein, or maybe our procalcitonin, those would be elevated as well, because we do have a source of infection and inflammation. So Dr. Wood will talk again a little bit later in the semester about periorbital cellulitis, but I want to mention it here as well. The child in the top picture does have periorbital cellulitis, so that cellulitis, around the periorbital area. And we are particularly worried about this condition because two different things. Number one, it can cause the infection, or just the location of the infection provides a very direct means of access to the brain and spinal cord. So that infection can is much more able and easy. It's a lot easier, for the infection to move and spread to the central nervous system, causing meningitis and encephalitis. And then secondly, that infection can cause damage to the optic nerve, and this can actually cause vision loss in the patient. So we want to have very astute assessment of, their vision. If they start reporting, blurry vision or loss of vision, that's very, very much reportable, and we want to let the providers know. So some additional infections, we'll, talk about two different fungal infections, and this is likely review as well. So we've got tinea, which is ringworm, and then candida, which is yeast. So these are caused by fungi. We see them especially in patients in areas where there is a warm, dark, moist environment, especially if there's a lot of sugar in that environment. So if you can, think this is why diabetics are at increased risk for yeast, because they are just so sweet and have lots of sugar, right? And then also immunocompromised patients, we're going to see an increased incidence of yeast infections just because their body and their immune system lacks the normal flora to keep those yeast, organisms at bay. So tinea, this is the fungus that causes ringworms. It can occur on the body, the feet, the head. And then candida, like I said, that causes yeast infections, and that can be present as thrush in the mouth. So that's the, white little hard-looking patches that we can't really scrape away without them starting to bleed. They can be very painful and cause decreased PO intake in our patient. And then also we can see yeast infections in the diaper area as a complication of diaper dermatitis, which we'll talk about. And that's going to be what's pictured in that top right. You can see It's very angry looking. It looks very painful, right? Like this is gonna be a very painful diaper change. I don't wanna, I would not be looking forward to that, but just very red and bumpy and raised. And just very, very angry looking. And then you can see the bottom picture is of ringworm, and it displays that characteristic kind of concentric circles. Um, and that's pretty characteristic of those lesions. As far as diagnosis is typically made, just visualization and then history of the patient. Our interventions are going to be topical medications, so topical antifungals. The ones for ringworm are listed in the pharmacy 19.2. And then we'll use nystatin for yeast infections. We can use that both orally and then topically. It comes as powders, creams, all that kind of stuff. And we want to make sure that we're not using steroid creams in addition to those, just because it can decrease the effectiveness of that. Moving on to dermatitis. So I'll talk about a couple different types of dermatitis. Now, this is on page 244 in your book. So atopic dermatitis is also known as eczema. It's the most common chronic skin condition in kids, so super common. You will see this. It is immune in nature, so our etiology and patho there is, immune related. And these kiddos are more likely to develop asthma and allergies later in life just because of that immune component. So it presents with dry, red, scaly patches, especially on the extensor surfaces and the, like flexor surfaces of the extremities. It can present on the face, on the shoulders, the back, kind of everywhere. Those patches are very, very itchy, and that chronic inflammation leads to something called lichenification, which is a fancy way to say that the skin in those areas gets very thick. These patients are also at increased risk for breakdown and infection because of the breach in integrity of their skin, right? And also adding insult to injury of the itching and constant, scratching of that itching can cause breakdown and infection. So our assessment and diagnosis is going to be done with inspection, and then also, certain triggers in the history that'll come up. Our interventions, we want to help them identify and avoid their triggers if we can. Sometimes it's not possible, but a lot of the times it is something that the skin is coming in contact with, or something in the diet, something like that. Moisturizers are very, very helpful. So those thick moisturizing creams, especially after a bath, and we want to educate for them to leave the skin a little bit moist and then put the moisturizers on top of that to really lock in that extra moisture. Tepid water baths are very comforting. So tepid means we're kind of in between, like warm and not super warm, not super hot, but we're not kind of, we're not cold either. Cold baths, that's just really mean, right? But we also don't want the bath water to be too hot just because that can cause irritation and a slight histamine release, which is only going to make the itching worse. So tepid baths are good. As far as medications go, we'll see topical steroids being prescribed pretty frequently, and then also some topical immunomodulating drugs. And those are going to have like really long, fancy names that you have trouble pronouncing. So you'll learn to recognize those pretty quickly. So with these topical medications, make sure you're educating them how to apply them correctly. So we just want a thin layer of that medication only to the affected area. We don't need to be slathering it all over the place like lotion, right? And your book has the pharmacy 17.2 that goes over some of these medications. And again, this is on page 244 in your book. Contact dermatitis. So this is we're going to talk about 3 different varieties: irritant, allergic, and diaper. These are on page 222 and 223 in your book. So irritant dermatitis is caused by contact with some kind of physical, mechanical, or chemical irritant. So this could be a cleaning product that parents are using. It could be, laundry detergent we're washing the clothes in, or maybe a soap that the child is being bathed in. Allergic dermatitis is immune mediated with T cells. So, we have this is an immune cause there. And so we're typically going to see that in response to plants, certain chemicals and things like that. So our patients or individuals that are allergic to poison ivy, that's going to fall under allergic dermatitis. And then diaper dermatitis is caused either by direct contact with the diaper itself, so the skin and something in the diaper, a substance or chemical, whatever, in the diaper just don't jive very well. Or more commonly, it's from the skin coming in contact with caustic urine or stool within the diaper. And yeast infections are very common as a result of that, which we talked about. And so these, a lot of these little pictures show, diaper dermatitis, but they've also got some yeast going on in there too, right? They look very angry and painful. Assessment and diagnosis will be by history and then just inspection. In our interventions here, we want to eliminate the exposure if we can, right, with all the types. Um, we're going to do topical and possibly even oral steroids with irritant and allergic dermatitis. Maybe even some, antihistamines to help with the itching and things like that. With all, we definitely want to prevent secondary infection because that can be a complication of all of these. And they're all going to display with a rash. Sorry, I forgot to mention that earlier. They're all going to display with a rash. It can be, difficult to differentiate between irritant and allergic sometimes, and that's where the history comes in clutch. Itching can also be a pretty strong manifestation, and then those lesions can be very painful as well. So we do, like I said, we do want to eliminate exposure. With diaper dermatitis, we want to make sure that we're changing diapers frequently and as much as we can. If we can air the booty out, that's what we want to do. Inpatient, it's not uncommon to see in the NICU or, peaceful or PICU a baby with really bad, diaper dermatitis and yeast and everything. And we let them be naked. And if they TT and poop on the linens, then we just roll with that as it comes, right? But using a lot of these barrier creams with zinc, so Desitin triple paste, Boudreaux's butt paste, and then Aquaphor is a really great barrier to keep that stool and urine off of the skin. Alternating that with just, letting those areas air out and dry out is really very, very helpful as our treatment options. And you've got patient teaching 30.2. And again, this is page 222 and 223 in your book. Seborrheic dermatitis, more commonly known as cradle cap. This is page 223 in your book. This is inflammatory in nature. It more frequently occurs on the scalp, but can affect the nose, eyebrows, and ears, usually in infants, but we can see it in adolescents as well. It presents with these characteristic scales you can see on the scalp of this baby and the eyebrows. And so our treatment is very mild. We're going to apply some kind of emollient, so that this can be, petroleum jelly or some kind of oil like vegetable oil, mineral oil, olive oil, coconut oil, just to help moisturize and loosen and soften all of those scales. And then we gently scrub them with a little brush and then kind of try to comb them away. And typically, this condition resolves by 1 year of age. Both of my kids have had this, and my youngest lost a certain little spot of his hair because he had it in one little spot, but it does typically go away. In really severe cases or cases that are spreading, we can see 1% hydrocortisone cream used. Moving on to acne, everyone's favorite thing, right? So, first and foremost, this condition has a big psychological impact, right? Especially when we think about the developmental period that it typically likes to rear its ugly head during puberty, right? So, just keep that in mind and be empathetic. So the proposed etiology and patho here is kind of multifactorial. We've got an increase in hormone production just during that, puberty time period, and that causes an increase in sebum or oil production on the skin. We've also got bacteria on our skin that between the bacteria and the oil, they're going to start to clog the pores, and that causes kind of a small little infection to start growing within the pores. And that's, the lovely little whitehead and things like that that we're trying to squeeze out of the pores. Presentation, it presents on the skin with, blackheads, whiteheads, comedones, which that's the stuff that you're trying to squeeze out of a pimple when you're when you're trying to squeeze it out, even though we all know we're not supposed to do that. And then we can also, in very long-standing and severe cases, especially nodular acne, can lead to scarring, which is very, very difficult to get rid of. Our treatment is going to be cleansing daily, twice daily with some kind of salicylic acid, sorry, or benzoyl peroxide product. Educating to not pop those pimples, so hands off, as difficult as that is, it really just makes things worse. And also, these patients need to use non-comedogenic products, so it should say that on the label, and that's just a fancy word that means it's not going to clog their pores any further. They can go to the dermatologist for, topical or oral antibiotics, and other topical and oral medications like retinoids, or females might be prescribed oral contraceptive pills just to help with those hormonal swings that they're going to get during their cycle. And the pharmacy 20.2 goes over this and the different medications. And then I want to mention a drug called isotretinoin here. So the brand name for this is Accutane. This is a very, I won't say it's widely used. It's typically reserved for persistent, moderate acne, or even like mild to moderate, very persistent acne that we have failed to treat effectively with all of the other things that we talked about. It's also used more commonly with the more severe nodular cases of acne that are going to cause those they're going to cause those pick marks and just that long-term scarring. So this drug is can be very dangerous. It is pregnancy category X. It will cause fetal harm if the patient takes it while she's pregnant. And so the prescription of this drug is very strict. They have to basically be a part of this iPledge program that makes them vouch that they are taking or on two reliable forms of birth control while they're taking this medication. They have to have a negative pregnancy test every month while they're taking this medication. They also have to have labs drawn to check their liver function. And so it's a very, very serious thing. And so education is very big with that. And mood swings are very, very common with this, and so are suicidal ideations. So we would want to monitor for those very closely. And it can also cause some pretty severe myalgia, so we want to educate them to expect that. And that's on page 312 and 313 in your book. Okay, moving on to lice. So this is one of the infestations we'll talk about. So this makes everyone's skin crawl, but it's very common in pediatric patients. There's a big stigma with any infestation, so make sure you're being empathetic whenever you're educating and dealing with a patient that has lice. It does not mean the patient or their family is, dirty. Lice actually prefer clean hair to move around in. It's just nature of the beast, having kids and working with kids. So it is spread by head-to-head contact. Typically, the infestation is on the head, right? Like I said, spread by head-to-head contact. They don't jump, they don't fly. They can't live off of a human for more than a couple of days. So these are all things we need to educate about because they're common misconceptions. The diagnosis is based on visualization of lice in the hair, on the scalp, and then also the nits, which are the little white things that you cannot flick off easily. So, dandruff versus nits. If you can easily remove, something white, then it's a piece of dandruff. It's not a nit. And then if you've got, live active lice bugs, and then you've got other white things, then odds are those are nits. So there are over-the-counter products that can be used to treat this. And then also if those fail, there are prescription products as well. The pharmacy 30.3 goes over those. That's your permethrin and malathion. We want to make sure that they understand it's very important to treat twice, 7 days apart. once to kill the active, live lice, and then the next time to kill those that were nits at the time of the first treatment. Then every night they need to remove the nits with a comb when the hair is wet, and they're not completely gone until there are no more nits found in the hair. Educate to not share things, so kids need to, be educated to not do this: helmets, hats, brushes, pillows, all that good stuff. And then let, everyone around the child know that they had lice. The school needs to know. If they go to daycare, they need to know. If they went sleepover somewhere, they need to know. Linens need to be washed in hot water, and anything that can't go in the washing machine needs to be bagged up for 72 hours. All right, burns. Now you will get an extensive burn lecture in fourth level, so I just want to lay a little foundation here and then also highlight the pediatric differences. So your book has a lot of really great, teach boxes about patient teaching regarding prevention and care at home, and then sunburn prevention, and I've listed those for you as well. And then also really great little box about comparing adult versus pediatric burns. So a big thing I want you to take away from this is that accidents definitely happen, and unintentional burns definitely do happen. But burns can be a very big red flag for non-accidental trauma and child abuse. So we always want to approach the situation with a very high level of suspicion. We want to look at the appearance of the burn. Burns that are circumferential, that go all the way around an extremity, like the child, or all the way around a certain part of the body, like the child has been dipped in something. That's a huge red flag. Burns on the butt, burns on the legs, those that look like they were burned with something like a cigarette or a cigar, or some other pattern that might be attributed to something being held next to the patient's skin to burn them on purpose. That's very, very, very suspicious. Also, listen to the story that the caregiver gives. Does it match what you're seeing on the patient? Also, is the story developmentally feasible for the child? Very unlikely that a 1-year-old is going to pull down a hot pot of boiling water on top of themselves and only burn their butt. So just, very high levels of suspicion here. Always advocate, the side of the patient. And also, just common sense there as well. Then educational topics like prevention and care at home. Inpatient wise, please realize that treatment for burns hurts. So we want to be utilizing adequate pain medications, pharmacologic and non-pharmacologic interventions, and then also utilize your resources like child life and, distraction, all that good stuff. Regression is also really common in regards to growth and development if a child's having to be admitted to be treated, in a burn center or something like that. So we want to be on lookout for that, and also, give the parents anticipatory guidance for that as well. And then widespread burns can also lead to sepsis, which we'll talk about, and infection and immune. And then also just because of that breach in skin integrity, right? Bacteria can get in. And then also SIRS, which is systemic inflammatory response syndrome, which you're going to learn more about in fourth level. But just, realize that that is something that we can see and we want to be aware of and monitor for. All right, last thing is injuries. So this is probably the more, complex topics that we'll talk about. So we'll talk about bites, and we're talking about insect bites, spider bites, animals, humans, you name it. Typically, we're going to see that localized reaction, those cardinal signs and symptoms of inflammation, right? Secondary infection is very common with any bite, so we want to make sure the patient's being treated for that and monitoring for it. Also, just, with certain specific critters, some things, some bites are different than others. Black widows are neurotoxic, so we have the potential to see some, neurocompromise there. Brown recluse bites are necrotizing, so it literally can start to eat the flesh where the bite occurred. And then with certain bites, we worry about disease transmission. So with animal bites, our big worry is rabies, right? We want to know the rabies vaccination status of the animal. And then with human bites, we're worried about HIV transmission. And then certain insects, we're worried about Rocky Mountain spotted fever, Lyme's disease, things like that. So our general care is going to be, if always err on the side of caution, go to urgent care, the ER, if the parent's worried about it. If we can bring the bug or spider or, whatever it was that bit the patient, that's great. If not, if we can bring a picture, that's just, that's better than nothing. But that helps identify, more specifically what bit the patient, and then that can narrow down the treatment to something more specific. We want to do cold compresses. So why would we do cold as opposed to warm or hot? Think about the way the two different temperatures are going to affect the blood vessels. Warmth or heat is going to cause vasodilation, right? And it's going to bring more blood to that area. Well, if we just had something bite a patient and inject venom into them, do we really want more blood flow to that area? We don't really want to spread that venom, right? So we're going to opt for cold compresses, so that causes vasoconstriction, and so we don't spread that venom. Also probably see steroids or potentially antihistamine creams or PO antihistamines, just for the itching that can occur with certain, especially insect bites. And like I said, we want to know the animal's vaccine status. We also want to know the patient's tetanus status, because they might need a booster if it's been a while. And also, just by the by, any animal bite needs to be reported to animal control. The provider is going to make sure to clean the wound, typically with normal saline or iodine, just because it's very gentle, and the iodine helps clean the wound and it doesn't destroy any of the tissues. Dog bites can be sutured shut typically. They'll typically leave cat bites open because they're at a much higher risk for infection because of the bacteria in a cat's mouth. And then also, like I said, we want to make sure we advocate for some kind of antibiotic coverage, just because secondary infection is very common with these. And our big thing here is going to be educating on prevention. And you've got a box 30.7 in your book that goes over that. So just, safety around animals and all that good stuff. Dog bites can be very, very, very catastrophic and very detrimental. I've seen a lot of really, really bad, dog bites. And sometimes, we even have so severe we have to get plastic surgery involved and things like that. So, educating on prevention and just safety around animals is really, really paramount. So snake bites, this is not in your book, but I feel like I would be doing you an injustice to not, teach you at least baseline information about snake bites with where we live, as much water as we live around, and all of the woods. If you work in any ER in Louisiana or take care of pediatric patients on the floor in the ICU, and really anywhere in Louisiana, you're going to take care of a snake bite. It's just the nature of it. So with snake bites, again, we want to get a picture of the snake if possible, if we can. And we want to keep that extremity in a neutral or dependent position. And that is, kind of the same situation as the cold versus warm. If we elevate that extremity, what is that going to do to the blood that is in the affected extremity? It's going to increase the return of that blood to the heart, right? And do we really want to spread more rapidly the blood that potentially has snake venom in it? No, we don't. So we want to keep that extremity in a neutral dependent position. Also, the same reason we really don't want them walking on that extremity if it's a lower extremity. Also, no oral suctioning or tourniquets. These are things that, have kind of been educated, passed down through the generations. They don't help. They can only, potentially cause tissue injury and damage. And if they don't help, then they're really just kind of exposing someone else to someone's blood and snake venom. So that's not beneficial. They also need to get to the hospital, as soon as possible, so that appropriate treatment can be implemented. We're always going to support their airway, breathing, and circulation first. Certain snakes can have neurotoxic venom, so respiratory compromise could occur. Others can cause certain coagulopathies, so maybe bleeding or clotting throughout the body. Um, it can also cause rhabdomyolysis, which if you haven't learned about before, you will in fourth level. And basically that just causes massive muscle tissue and cell breakdown, and it can cause very fatal electrolyte imbalances and also kidney failure. So as long as airway, breathing, and circulation are stable, we're going to move on to administering targeted antivenom, and that's going to be your Anavip or your Crofab. And so that helps neutralize the venom within the patient's body system. Secondary infection is very common, so we want to, this patient's going to require antibiotics. Just like with cellulitis, we want to monitor for extension here. So you can see in this patient's lower extremity, they've been marking up the leg as the swelling and kind of bruising and symptomatic tissue spreads. And just look at that extremity, guys. I'm worried about lots of things, right? Look at all of the bruising and swelling from the bleeding within those tissues. And so we really, really got to be monitoring neurovascular status there, right? This extremity is high risk for compartment syndrome, high risk for neurovascular compromise. So we need to be checking those 5 Ps, right? And we need to be in very close contact and communication with the provider about any changes to that extremity. Also with the antivenom, it's not a blood product, but we kind of treat it like it is because the patient has the potential to react negatively, just like a blood product. So they need to be continuously monitored. A lot of times we will pre-medicate them with Tylenol and Benadryl, and then, we want to stop the infusion if they start exhibiting any of those signs of intolerance.